viewers, I am back once again with the topic on temporary anchorage devices in orthodontics part 2. And for those who have missed part 1, I would request them to go into the link and then get yourselves acquainted with part 1 such that there is a continuity in your understanding of the temporary anchorage devices in orthodontics. So, in part 2, we shall be dealing with the instruments which are used for the placement of the microimplant, the two methods, namely the open method and the closed method, and the types of driving methods and the head shapes, different types of head shapes of the microimplant, and the sites of microimplant placement in maxilla. So, what are the instruments for microimplant surgical procedures? We first use the round burr, which could be a number 2 round burr of a diameter of about 0.9 millimeter. Then we can use a pilot drill whose diameter could be 0.9 or 1 or 1.1 or 1.2 millimeter, and the length can be short, which could be 24 millimeters, with a 6 millimeter drill tip length which is used for penetrating the bone on the buccal side. We can use a medium length one which is about 25 millimeters and a long one which is about 31 millimeters. And in the long one we have an 11 millimeter drill tip length which is used for penetrating bone on the palatal side. Now, how do we actually place these implants? We use the standard long handle drivers to drive the microimplants into the buccal and the labial cortical plate of both arches. We also have the long handle drivers with built-in torque gauge, and the torque resisting force can be adjusted up to 2 kilograms centimeter. We also have the standard short handle drivers to drive the microimplants in the palatal area, because it is going to be a little bit difficult for you to use the long handle ones. We can also use the engine driver with an extra long length which is 36 millimeter, a long length which is about 26 millimeter, a medium length which is about 19 millimeters, and a short length which is about 17 millimeters. We can also use a speed reduction contra angle handpiece, and that which is used for drilling could be 64:1 or 16:1 ratio, or a 256:1 reduction which is used for driving and for removal of the microimplants. And this is an implant engine which you could use if you have one. So, now for the novice, he would like to know how best and where can I place this implant. You can make a prefabricated wire element which you call the locator, immerse it into acrylic, place it over the occlusal surfaces of the mandibular teeth so far as this particular diagram is concerned, and then you could see that that locator is there with a helical loop, and you can approximately place the microimplant there such that there is no confusion in your placement of the same. Or you can make a zigzag wire just bonded to the first premolar. For example, you want to place it between the first and the second premolar, and then you have that little helical loop at the bottom of that zigzag wire. You can take an X-ray also, and then if you know exactly where the center of the helical loop is, you can place the implant in the correct position. So, it's just to aid you to place it at the correct position without injuring the adjacent tooth roots. Kim has also used a stent where he has used thick gauge wire. He made it into a sort of a right angle wire, and then he has just soldered a few little strips of that wire at 1 millimeter apart, and then when you take an X-ray, you know exactly the interradicular portion of the bone, and you know in which two wires the interradicular bone is present, so that when you place your microimplant, you do not place it in the wrong position and injure the root. Well, these are little tips to help the novice, but then over a period of time, as you become more and more used to placement, you may not need all these little devices to aid you in the placement of the microimplant. So, what do we know as the open method and the closed method? It only means that the head of the microimplant needs to be exposed, or does it need to be closed? So in an open method, the microimplant is placed in attached gingiva, the ideal position to place a microimplant, and the head is exposed in the oral cavity. So this becomes an incision-free method when the microimplant is placed in the attached gingiva. Now what do we call a closed method? If the microimplant has to be placed in the movable soft tissue such as the alveolar mucosa, then you need to make a small nick in the alveolar mucosa, and then the microimplant is placed, and then you need to also have a ligature wire jutting out so that you're able to place your spring or your E-chain, etc., etc. So there you can see the hook with a ligature wire that extends to the attached gingival area. This needs to be done when you place it in the alveolar mucosa. So the periodontal condition is an important factor in the vertical placement of a microimplant. So you can see the tooth and the periodontal structures around it. You can see the mucogingival junction, and you can see the epithelium and the connective tissue attachment. So between these two junctions, you have the insertion site. We get more into the details of the same as we keep moving ahead. Driving method. Now how do we drive this implant? We have got two methods. We know it is known as the pre-drilling method, known as the self-tapping, wherein the tunnel is drilled into bone with a pilot drill, which is supposedly 0.2 to 0.3 millimeter smaller in diameter than the microimplant. And these microimplants are made up of, as we all know, low-grade pure titanium and are of small diameter. So what is the other method? It is the self-drilling or the drilling-free method, where the implant itself acts as a drill. These implants are also made up of titanium alloy, but they are of little larger diameter. Here, the tip and the screw threads are sharper. So you have to be a little bit careful such that you do not injure the adjacent roots. So what are the different types of microimplant shapes of the head? We've got the small head, which we call it as the SH type. We've got a no head, which is the NH type. We've got the long head, which is the LH type. We've got a circle head, which is the CH type. We've got the fixation head, which is known as the FH type. And we have the bracket head, which is known as the BH type, which could be a right-handed one or a left-handed one. So here you have to be a little bit careful. When you place the left-handed screw, you have to turn the screw in a counterclockwise direction during insertion, whereas in a right-handed screw, you need to put the screw in a clockwise direction. These bracket head types of microimplants are also pretty useful, and if you're going to use it in between the maxillary first molar and the maxillary second premolar, if you're going to use a bracket head on either sides, you can use an intrusion arch. The Ricketts utility arch could be used to bring about effective intrusion. And then you can also use these bracket head type implants for molar uprighting, a very good piece in the armamentarium for the orthodontist. Otherwise, sometimes it becomes very difficult for us to upright these teeth, and it's just an implant placed between the mandibular first molar and the mandibular second premolar, the bracketed type with a hook and with a lingual button bonded onto the lingual surface of the mandibular second molar, and by using a chain or an elastic, you can upright it. All this is a little bit, I wouldn't say impossible, a little bit difficult with your traditional fixed mechanics, right? Maxilla. So now we would like to see where all you can place these microimplants. Which are those sites where these microimplants can be placed? They can be placed in the infrazygomatic crest area, in the maxillary tuberosity area, between the first and the second molar buccally, between the first molar and the second premolar buccally, between the canine and the first premolar buccally, between the maxillary incisors facially, between the second premolar and first molar palatally, between the first and the second molar palatally, and in the mid-palatal area. Now let us go into the details of each site of microimplant placement. Now when it comes to the maxilla, the infrazygomatic crest area, you can use microimplant of about 1.3 to 1.4 millimeter and a length of about 5 to 6 millimeter. Why do you need to place it here? So this location can be used for retracting the entire maxillary dentition to correct the class 2 canine and the molar relationships. You can also bring about intrusion of maxillary molars if palatal microimplants are also used concurrently, and intrusion of maxillary anterior teeth. Because here the vertical force is more than the horizontal force. But then this particular area, which is the infrazygomatic area, the surgical considerations are there. We need to be a little bit careful because we are very close to the maxillary sinus. Maxillary tuberosity area. So what's the diameter that could be used here? It could be 1.3 to about 1.5 millimeters, and a length of about 7 to 8 millimeters can be used. What's the purpose? This location, that is the maxillary tuberosity area, is used for retracting the maxillary posterior teeth when the third molars are missing or have been extracted and healing is complete. Surgical considerations. The quality of the cortical bone is compromised here, but incision is not needed for drilling because of the good coverage of the attached gingiva. Here you can use it between the first and the second molar buccally, diameter 1.2 to 1.3 millimeters and with a length of about 7 to 8 millimeters. The purpose: you can retract the maxillary anterior teeth and is an excellent site for intrusion of maxillary molars. Good attached gingiva is present here, so no incision is required. But if there is a mobile soft tissue area, vertical incision is required before drilling. That is as the case may be. Between the first and the second molar buccally, just correlate with the figure on the right side. Just see where the microimplant is placed, just see where the crimpable hook is placed and the retraction coil spring. So just keep an eye on the right figure and then you would understand what I am trying to convey. Most important thing here that all should know: the root of the maxillary second molar is tipped mesially. Hence, there is not enough space between the first molar and the second molar roots. The second molar root is then moved distally by leveling. So when you use your fixed appliances, you can do a little bit of leveling and move the root a little bit distally. When you do that, you get an average distance between the first and the second molars of about 2.1 millimeter at a level 5 to 7 millimeters apical to the alveolar crest. So just visualize the figure on the right side. A diameter of about 1.2 to 1.3 millimeters can be used. A length of about 7 to 8 millimeters can be used. What's the purpose? It's an ideal area for retraction of maxillary anterior teeth and intrusion of maxillary molars. This site is a very common site which we all use in our clinical practice. Higher the position, the path of the drill has to be angled perpendicular to the roots of the teeth to avoid sinus injury when the sinus wall is low. Because here the sinus wall tends to dip in, so you have to be a little bit careful. The average thickness of the cortical bone in this area is about 1 to 1.5 millimeters. Between first molar and second premolar buccally, so dear viewers, look at the figure on the right. The mesiobuccal root of the maxillary first molar seems to be curved mesially. The average distance between the first molar and the second premolar roots is 3.2 millimeters at a level 5 to 7 millimeter apical to the alveolar crest. So if you want to avoid root injury here, then you have to place the microimplant diagonally and mesial to the contact point. If space is narrow, create enough space by leveling the two roots as I have just mentioned before. These are very important points that needs to be taken into account. Yes, you can also place it between the canine and the premolar buccally. A diameter of about 1.2 millimeter can be used to 1.3. The length is 7 to 8 millimeter. because the quality of the attached gingiva is very good in this region. You can also use it between canine and premolar buccally, but what is the purpose here? It is very useful for moving the molars distally or mesially, and for this the microimplants are placed closer to the gingival margin. Yes, you can also place it between the canine and the premolar buccally for the intrusion of buccal segments, and if they are placed a little bit higher, the intrusion is more effective. So you can see where all these microimplants can be placed between all the teeth, second molar to first molar to second premolar to first premolar to canine, not to say the least, even between the maxillary incisors, facially. Yes, the diameter could be about 1.3 to 1.6 millimeter with a length of about 6 to 7 millimeters. Now what is the purpose here? To intrude and to have good torque control of the maxillary incisors. There is a good quality cortical bone here and there is good attached gingiva. So if the microimplants are placed at a higher position to produce intrusion of the incisors, you get effective intrusion. Certain times it is pretty close to the labial frenum, so at times the soft tissue grows around the head. In that scenario, a ligature wire has to jut out from the microimplant head to the attached gingiva. All this is if required. Here you can place it in a perpendicular direction due to a large space between the roots of the incisors. So you can see here it's placed in between the maxillary incisors. On the right side you can see the clinical case. But then to have more effective intrusion, it's better you place the microimplants between central and the lateral incisor roots. These are very important sites for you to correct the canted occlusal plane. A canted maxillary occlusal plane is at times very difficult to correct with our conventional fixed appliances. But then with the advent of these microimplants, we are able to correct the canted maxillary occlusal plane, and that does a volume of good to the person when he smiles, because everyone is concerned about their smile and what shows out the incisal edges of your maxillary anteriors. So if there is going to be a cant, it looks a little bit unaesthetic and non-consonant, isn't it? Yes, you can also place it palatally. We spoke about buccally, but yes, of course you can also place it palatally. Where? Between the second premolar and the first molar, as also between the first and the second molar, because you have 4.03 millimeter of interradicular space between 6 and 7 on the lingual side or the palatal side. Now why do we have to place here and why is it so useful? I will let you know shortly. Yes, as I just mentioned, you can use a 1.3 diameter to about 1.6 millimeter diameter microimplant, but the length here is 10 to 12, not 7 to 8. Why? Because the palate we have a thick mucoperiosteum. So your microimplant has to pass first through the thick mucoperiosteum and then reach the bone. Hence, you require a longer microimplant of length of about 10 to 12 millimeters. This is very useful for intrusion of maxillary molars for open bite correction. It does a volume of good for the patient. But then you need to take a little bit of precaution, because as we all know, we have the greater palatine nerve traversing the palate, so be careful of not injuring it. And you have the vault of the palate. Some have shallow vaults, some have got high arched. So that's the reason you need to have a good knowledge of the anatomical considerations. Then comes your surgical considerations, and then comes your skill of placing it. As just mentioned to you, you can also take a periodontal probe, try to pierce it through the mucoperiosteum after having given a little bit of topical anesthesia or a little bit of infiltration anesthesia to check how much the probe dips into the thickened mucoperiosteum. So now we have a good idea as to how much it has to penetrate through the thickened mucoperiosteum, and then the rest of the screw needs to reach into the palatal bone. Well, in lingual orthodontics, I don't presume we are using this technique more now, But then when it was used, and even some practitioners do use this technique even as of now, if you place the microimplant between the first and the second molars, there is a greater range of action for the elastic material, and you can achieve an en masse retraction for the very simple reason that a force is more closer towards the center of resistance, and that's the reason you're having en masse retraction, to a great extent a translatory movement. So, can we give an implant in the mid-palatal area? Of course. A diameter of about 1.5 to 1.8 millimeters can be used, but the length can be about 5 to 6 millimeter. The purpose, any kind of tooth movement of maxillary posterior teeth, including unilateral constriction of the arch. A microimplant can be attached to the transpalatal arch for improving anchorage and for mesializing and distalizing molars. Surgical considerations. No incision is required here. There is a good quality cortical bone, and the thicker diameter microimplants work better in patent sutures, sutures which are slightly opened, younger children. If the suture does not offer resistance, then the microimplant is placed adjacent to the mid-palatal suture. A little bit of caution, a little bit close to the nasal cavity, so take some precaution. So here you can see the mid-palatal microimplants which are used for unilateral constriction of the maxillary arch. So what we mean by that, if your maxillary first molar and the second molar have been buccally tipped, then by using these mid-palatal microimplants and by using whatever your force, your elastics or elastomeric module, etc., to the hook which is soldered to the lingual portion of the maxillary first molar, you can bring about constriction of the buccally tipped maxillary molars. It's lovely that a microimplant in the mid-palatal area can do this particular action too. Yes, you can also use the bracket head. I already mentioned to you different types of heads. Where does the bracket head type come into play? Yes, you can place it in between the mid-palatal area to distalize the first molars. This is another example of a palatal implant by Benedict Wilms, where the maxillary first and the second molars can be distalized effectively, and the whole anchorage is borne by the palatal implant. So dear viewers, thank you all for a patient listening. With that, we come to the end of part 2. In part 3, we shall be dealing with the sites of microimplant placement in the mandible, as also a little bit of information about the extra-alveolar screws, namely the infrazygomatic crest screws, as also the mandibular buccal shelf screws. Thank you all.